Next talk is by dear Dr. Namrata Madam. She needs no introduction. She's a versatile surgeon and a great administrator. And she is currently the chairman scientific committee ISOS. Madam will be talking on intraoperative OCT guided phacoemulsification, seeing the unseen. Over to you, Madam.
Thank you, Dr. Sandhya. Thank you for making me a part of this important course. Can I have my presentation, please? So, final IOCT. Final IOCT. If it's not there, I can present from my laptop. So, not that you need intraop OCT microscope, only thing is that it just helps you to make the mouse is not, it just helps you to understand the dynamics better. Timer you have put? So I'll be talking about this, and important thing is one has to understand all your diagnostics are now marching into your operation theatre and they are getting wedded to it. So this intraop OCT is actually inside the operating microscope, and again no financial interests are there, but like you make a side port. So this comes in a small window like this on one side, and you can see that the side port is being made. Then you make uniplanar incision, multiplanar incision, biplanar incision. Then again, you can see that incision is being made. Then as you do capsulorhexis, you focus on the lens. So the flap is initiated here, and then this flap can also be seen in the lens. Now for a clear cornea, this is okay, but if the cornea is hazy, then it just helps you to pick up your flap if you have lost your flap underneath that haze. Of course, there is not much to hydrodissection, except that you will see the separation of the posterior capsule from the from the cortex and the nuclear complex. And again, this becomes useful when you're dealing with the posterior polar cataract. Then as you do sculpt, you can see what is the depth, comparing it with the plate which is left behind. So you know at what level you have sculpted. So this is almost 70% there. Then after doing the phacoemulsification, this is the cortex, the PC which moves up as your phaco probe comes out, because everything tends to move up. The posterior capsule bulges there. So when you put viscoelastic, the posterior capsule drops down, and again you can see here. Intact PC can be very well identified here. Then intraocular lens insertion is done again through the wound. You can actually see how it is getting done here. And then I think important thing is the viscoelastic aspiration. So once this, sorry. So once this intraocular lens is in position, is in the bag, you place it in the bag, and then you see the gap between the PC and your IOL. So viscoelastic is there, so this gap would be more. And when you aspirate the viscoelastic, this gap decreases. Sometimes it sits very snugly with the posterior capsule. So this changes the effective lens position vis-a-vis the bag, and I think this may have a role in future for IOL power calculation. Then as you hydrate the wound, you can see the spindle of hydration there, and also you can see the gape is present anteriorly, but it has closed posteriorly, something which you may not be able to appreciate in the presence of the haze of the hydration. Then sometimes again, when there are wound side DMDs, small DMDs which are present not visualized here, you can actually pick them up here, and at the end maybe put an air bubble to see that the wound side DMD, port side DMD is attached, as can be seen. A small frill can be seen here but cannot be seen here. Then subsequently, it is useful in different situations, such as in posterior subcapsular cataract. So PC is quite intact here, and you know that this is not a posterior polar cataract. So when it is a posterior polar cataract, you will again know whether the PC is intact or the PC is broken. So you can plan your surgery likewise. So for instance, this is a posterior polar cataract, the disc is sitting there. Now if it is a white cataract, you see these black areas, you can be sure that once you give a nick, the fluid will not come out, because the interlenticular pressure is not that high, and then one can complete one's capsulorhexis without the fluid which is coming out. Now, when you don't have these black areas, it means that the intralenticular pressure is really high, like this, no black area. So one can be absolutely sure that if you give a nick on this capsule, the fluid is going to come out. And you see the fluid coming out like a blob, which is coming over there, liquefied cortex. So these are some of the important findings or some of the important dynamics. Now this is again a posterior subcapsular cataract. Notice that the PC is quite intact, and as this wave of hydration goes, the whole thing, PC drops down, this whole thing is separated and there is a gap here. So again, can be sure that the PC is intact. Now here, notice that this is already looking irregular, ragged, moth-eaten appearance, and there is a PC defect there. So it helps you to plan the surgery right on the table and to change your plan accordingly if you have intraop OCT microscope. We did do the study on looking at the gap, and we found that it varies with the type of the lens, and it has connotations as far as the best corrected visual acuity is concerned. Then we described what is called as the butterfly antenna sign. That is, this case was a case which is post-traumatic, so the anterior capsule was scrolled out like this, like the butterfly antenna, which can be seen here. Nothing great to it, but then this is kind of scrolled out and this PC is intact, and so you can place your lens there. Then I think this is what we published. Then I think this is extremely important. This was a case again of cataract flex was done for this case, and there was a posterior capsular rent. Now all the cortex matter etc. can be seen here, but more importantly you can see the PC tear, and the PC tear looks like a scrolled PC. So once you have that scroll of a PC here with a gap, that means the posterior capsule is torn, and then you have to again plan your surgery likewise. Again, very useful when you have haze or you can't make out whether the PC tear is or not. So you focus on this, and this scroll sign can be seen here. Most useful, I think, for desmetopexy. This is Descemet's membrane detachment referred from elsewhere. So you put the air bubble. Now, if I didn't have this, I would think I'm done, but I'm not done because there's still some gap which is present between your detached Descemet's membrane and the stroma. So what do? You keep that pressure on for good 7 to 8 minutes and also do external massage. So once you do that on the table itself, the cornea will clear. Even if you don't have IOCT, you can make out. And plus this thing will get attached. And when you get out the needle, then put some pressure there so that your air or gas doesn't come out with your needle itself. Now again, Descemet's membrane detachment, complicated case. You can see that there is a DMD hanging there. Once you put air bubble, still the gap is there. So you make incisions which are from the top. So we call them venting incisions, so that you drain out the fluid from the top, and then now you put air. So once you drain out the fluid, this is the gap decreased, and when you put the air, it is quite attached. So like I said, it helps you to understand this, and I think this is the last one referred by another surgeon. Whole disc of this Descemet's membrane came out, and two hours later the patient was referred to us, and we didn't know which side is up, which side is down, because he put it back and sent it to us. So what we did, we looked at the intraop OCT microscope. So once you have this biceps curl configuration, it means the endothelium is staring down, looking at you, which means that you are in the correct way up. So now we've got, I call it autodemic because it was the patient's own Descemet's membrane which we got to stuck to the back of the cornea. This was a review article in Survey of Ophthalmology on IOCT guided anterior segment surgeries. And I think it really helps. I know it's expensive, but I'm sure Indian companies are coming out with their indigenous models, and it will be affordable very soon. So again, invite you all to Jaipur in March. I hope people will block their dates and be there. And again, my humble request for this help. Thank you so much for your kind attention.
Thank you, madam, for that